and I threw in hearing preservation because I don't think I'd have more than about 5 minutes to talk about restoration. We'll talk about it, but it's so difficult, and I'll try to help you understand why I think it's a difficult topic. As far as my other disclosures today, I do have a consulting relationship with a number of groups who are working on NF2, which I'm happy to disclose. None of them are conflicts in this talk. I also have to disclose that it's my wife's and my anniversary today, and so I can't stay for the whole program, but we're excited to be here, and I would love to see the recorded view of all of the presentations later. So I'm just going to summarize and talk about the top half of this slide. We're going to talk about mechanisms of hearing loss from vestibular schwannomas, hearing preservation, restoration, and rehabilitation. And the bottom half I'm leaving to Dr. Jordan, who'll be following me, who's going to talk about clinical trials and some of these other things. I will just make one or two quick points about that. I don't think I need to spend a lot of time describing the disease to most of you. I believe that you all know NF2 quite well. I will just point out that many people call the tumors that I'll be talking about today acoustic neuromas. However, they are misnamed. They really are vestibular schwannomas. They don't occur on the acoustic nerve most of the time. They occur on the balance nerves, and they are Schwann cell tumors, not neuromas. So I prefer to use vestibular schwannoma, even though it's got one more syllable. The symptoms associated with the vestibular schwannomas and NF2 are well known, and I will only focus today on hearing loss, although I think it's important when we think about the hearing loss that we have to consider all of our priorities when we're talking about treatments. And that is that preservation of life and quality of life are very important, and hearing is one section of that. But we do have to consider all of the other aspects as we plan and talk about what we're going to do for hearing loss. So we have a number of different tests we do to help us understand hearing, and I'm sure you're familiar with most of these, and I'm going to just talk about a couple of these briefly to try to help understand why I think they're important. The audiogram, as you know, is usually we test two general things. One is we test the level of the pure tones. When we give the patient a tone, they tell us, do they hear it at what level? Right ear is usually in red, convention is left ear blue. And the better the pure tones, the higher they are in the chart, the better the overall hearing is. More importantly is the word discrimination score. How clear is the sound? If the clarity is 96% or 98%, we say that's wonderful. Even if the pure tones are very good, if the clarity is 50% or worse, then certainly it's much more difficult to hear in that kind of environment. And we have to take into consideration the clarity of the signal as well as the loudness of the signal. Another test that we don't really use very often is the hearing and noise test, but as you all know, hearing is tested in a soundproof booth, and so it's the ideal listening situation. But in the real world, there's always background noise and interfering signals to make it more difficult to hear. So this is a test which gives us some background noise. The normal pattern of progressive hearing loss is what we see for most patients with NF2. It's usually gradually and slowly progressive. But there are some patients that present with sudden hearing loss, and sometimes treatment with steroids will reverse that. It's only about 5% to 10% of patients that have sudden hearing loss, but it is important because it may respond to steroids. The auditory brainstem response test. This is a test that we use that's useful when we're intraoperatively trying to monitor the hearing. Sometimes it's not present because of the presence of the tumor, so we can't use it as a way to monitor. Clicks are played in the ear, and about 2,000 clicks are gathered over a 3 to 5 minute period with electrodes on the head. I'll show you here in 1 second. Another way we can measure it is by directly measuring the signal in the cochlear nerve itself. We also do some balance nerve testing, and it pertains to hearing loss because the location of the tumor within the canal and against the hearing nerve somewhat depends on which balance nerve it starts on. So Electromnystagmography measures the activity of the balance organ. It's performed by placing warm or cool air in the ear or water in the ear canal, and we measure the eye motions. And it might help us predict who's going to do well after surgery in terms of their balance recovery. It also helps to predict which tumors are pressing against the cochlear nerve. Vestibular evoked myogenic potentials. There's another test we use where we play clicks in the ear, and we measure the response in the neck muscles to the clicks in the ear. And it also may help us determine the nerve of origin of the schwannoma, which may relate to the hearing loss. Vestibular ocular reflex is a reflex that we have when we turn our heads quickly. Our eyes tend to track what we're looking at. And the way that our eyes respond to our balance nerves is also helpful in terms of predicting how patients are going to respond to surgery. So you're all familiar with the current treatment options of observation, radiation, and surgery. And I will talk a little bit about the pros and cons of each of those in terms of hearing as we go through. It's also, I think, important, and this is one of the slides I wanted to concentrate on for a minute, is that we don't really know for certain all of the mechanisms of hearing loss in vestibular schwannomas. It's commonly discussed as though compression of the auditory nerve by the tumor next to it may be one mechanism. But interestingly, there's a lack of correlation with tumor size and hearing loss. Some small tumors cause hearing loss, some very large hearing tumors don't. And so compression may not be that relevant. Sometimes we see progressive change in hearing with the hearing going down without any evidence of tumor growth. And a sudden hearing loss can occur in up to 20% of patients with schwannomas without demonstration of additional tumor growth. So growth and compression are not necessarily associated directly with hearing loss. What about a lack of blood flow getting from through the tumor into the inner ear? Could this cause damage to the hearing? Well, yes, it does. We see that in patients who've donated their temporal bones, and we can see there's small areas, a little hemorrhage or bleeding or fibrosis into the tumors. But this is a very small fraction of the tumors that we see this on. So we think, although it may be a mechanism for hearing loss, the blockage of blood flow, the inner ear is very sensitive to lack of blood flow. It's not very many patients where that's a high likelihood. What about direct invasion of the cochlea with the tumor, or a conductive hearing loss from the tumor sitting up against the ossicles, the hearing bones, and preventing them from vibrating? We do know that this is another mechanism, another couple of mechanisms that are in play here. When we look at a human temporal bone with a patient that has a tumor sitting in the internal auditory canal, the bone is shown by the darker purple and the tumor is shown by the lighter pink here. And we can see the auditory nerve running right along the face of the tumor here. And so the question becomes, is the hearing loss from the cochlea here, or is it from a retrocochlear, the tumor in the canal? And we have evidence to talk about both of these. We see, if we look inside of the cochlea, that there are some abnormalities. The little tiny hair cells that are receptors for sound are lost in many patients that have NF2. Likewise, this center cavity, which is usually very high in a potassium concentrated fluid, gets filled up with this material that's, we don't know for sure what it is. We call it here a pink precipitate, and acidophilic precipitate. And we also see some loss of this area called the stria, which is really important for exchanging ions into the part of the inner ear. And so it's possible that when patients go on to bevacizumab or Avastin, that some of these cells start working a little bit better, and maybe we clear out some of this precipitate. Maybe that's why bevacizumab helps. But there are certainly things in the inner ear, like when these hair cells are lost, that's a permanent condition, and that doesn't get restored with Avastin. So there's an interesting finding from Dr. Ashwaragi's group in the NIH a few years ago, where they saw that inside of the cochlea, this is an MRI that looks really fuzzy compared to most of the resolution you see, but inside of the cochlea, we can see that there are areas where a protein lights up in patients that have hearing loss. And this pre-contrast flare-weighted image helps us to associate damage to the inner ear with the effect of the tumor, and lets us know if there's something going on from the tumor that's affecting the cochlear portion of the hearing. So one of the signals that we can check is we can see if these inner hair cells put out their normal emissions. They call them otoacoustic emissions. We see that in patients with schwannomas, these get knocked down, which says some of these outer hair cells are not functioning properly. We also see considerable atrophy of the cochlea, as I just showed you on the previous slide. And the surprising reversal of hearing in about 40% of patients on bevacizumab, and Dr. Jordan will talk about that more. But this is very interesting finding, and says that not all of those cells are dead. They're just, some of them are sick, and we can maybe make them better for a while. Another thing that's come up in the last few years by Dr. Stankovic's lab is that there are little vesicles, little bubbles of fluid that are secreted out of the tumors that may cause increase in hearing loss. We know that one of these is called tumor necrosis factor alpha that is very damaging to the hearing. There are others that may be protective against hearing loss. FGF2 seems to be associated with better hearing. Just recently, in some work that's not been published yet, we found that the connection of the nerves going into the inner ear may also be damaged. This requires more study, but it might be a connection between the nerve as well as some of these other features we've talked about. So as you can see, hearing loss in vestibular schwannomas with NF2 is very complicated. There are many things that can be damaged or aggravated. This just shows what an ABR does. This is a far field response where we put electrodes on the head, the forehead, up at the vertex of the head, behind the ear, and so forth, and then clicks are played in the ear. And as the sound goes into the cochlea and goes up through the brainstem and out to the auditory tracts in the brain, it creates different waves, and these wave patterns are measured. And we look at those and we say, okay, the first wave may be coming from the cochlea, the second wave through the eighth nerve, and so forth. And this is something that we can monitor and get an idea about how much damage has been done to the inner ear and to the auditory nerves by the tumor. It gives us a more detailed mechanism. It takes about 2,000 of these 2,000 of these clicks to accumulate the message, and it takes 3 or 4 minutes to get a wave tracing. So intraoperatively, it can be helpful, but it's a little bit slow. We'd like it to be faster. The intraoperative direct eighth nerve monitoring can be done by monitoring the electrical energy that's put out by the cochlea and the nerves when they contract, when the synapses occur through them. And this can be measured in various places along the nerve. Sometimes the advantage is that it only takes about 100 clicks to get a signal, and we can get a nice look at the action potential. However, having an electrode in the field where we're operating is a little bit of a nuisance and can be dangerous, and getting good contact with the cochlear nerve when it's very splayed out or hidden by the tumor can be tricky, but a useful measurement, I think. Let me just show you a couple of examples of what I'm talking about in terms of the size of the tumor not making too much difference. So here's a patient who has a very small little tumor here that's in the internal auditory canal, you can see. And the hearing in the right ear is shown in the red, the blue is the left, and there's some high frequency drop off in that left ear a little bit. But overall, the pure tones are quite good in the low and the mid frequencies. And the word discrimination score is 98% in the right ear and 96% in the left ear. Here's another tumor of similar size in a 63-year-old woman with some pure tone loss in the right ear. The left ear has some high frequency loss too, but not as much. And when we look at the overall clarity score, we say the right ear has 48% word discrimination and 100% in the left ear. When we look at that discrimination, we say, wow, that's really pretty poor for this amount of hearing loss. But that's one of the hallmarks of retrocochlear pathology, when there's a disruption of the synchronous firing of the nerves. If that gets disrupted, the clarity of the sound really goes down. Here's another small tumor on the right with quite a bit of pure tone hearing loss and word discrimination score of 8. And here's a much larger tumor on the other side with a little bit of pure tone loss and 100% word recognition score in the left ear as well as the right. So you can see how the size of the tumor doesn't necessarily make a difference. Here's a patient that had a very large tumor and also had some cystic formation within the tumor, and these can affect the hearing or not. Her hearing was actually not too bad. You can see here on the left, the hearing, and the right, the pure tone averages were overall very good, and her discrimination was 88% in the right ear with quite a large cystic ugly looking tumor. What about our success in terms of trying to preserve hearing when we take these things out surgically? Well, it's not great. As a surgeon, it hurts my feelings to say that, but we try our best, and there are certain factors that play into this. If the nerve on which the tumor starts is the upper of the two balance nerves, the superior vestibular nerve, our ability to preserve the hearing is poorer than if it's on the lower of the two balance nerves. Most of the time, we're not able to say preoperatively which nerve it starts on because the tumors have completely filled the canal. But when they're smaller, we can tell. And so earlier, this is from an earlier study we did back in 2007, but only about 15% of the patients were attempting hearing preservation because their hearing was already so poor. But when the patient had the tumor originate on the superior vestibular nerve, we had a 75% success rate where we had better than 50% word understanding preserved. But when it was on the lower of the two balance nerves, the success rate went down substantially. This is an interesting study also where this is more recent. We looked at small tumors and we could tell exactly where they came from because they were small enough on the superior and inferior vestibular nerve. We also found that some of them do originate on the cochlear nerve, some on the facial nerve, and 16% were indeterminate. But tumors that are very small, that are out lateral in the internal canal, this is a view of a tumor that's kind of shown in relief with the spinal fluid around it, very bright white, and the fluid in the cochlea white. The tumors that are more lateral in the canal are more difficult to save the hearing than those who are more medial in the canal. So if we chose an ideal tumor, if we're trying to preserve hearing surgically, we would say they would be on the upper of the two balance nerves, and they would be away from the cochlea. They'd be in the middle of the canal instead of out right next to the cochlea here. So here is a tumor that we can see on the coronal section as though the patient's standing here facing us. And this is on the lower of the two balance nerves. The other one would be up in this area. It's a very small tumor, and we can see that it's in the back of the canal on this scan. And so we say this is most likely an inferior vestibular nerve tumor. And it may be close to the cochlea, but it's small enough that we may have an opportunity to try to preserve the hearing. It is not, fortunately, pushed up right against the cochlea here. You can see the cochlear nerve are separate from the tumor in this location. Another element in terms of trying to preserve hearing has to do with the anatomy of the tumor on a microscopic level. And what we're looking at on this view is a tumor that's sitting in the internal auditory canal and the nerve next to it. And when we stain the nerve filaments that show it, it's even more clear that this is the nerve, this is the normal eighth nerve, and this is the tumor sitting next to it, and it comes right up to it and it butts it. But there's certainly a potential cleavage plane where the tumor could be removed and the cochlear nerve left intact surgically. This is another tumor where we can see the cochlea, the eighth cranial nerve coming out, and then it comes down and abuts the tumor here. And when we look at it in a higher magnification and we stain for the neural elements, you can see there's really not a distinct cleavage plane between the tumor and the nerve. And it makes it much more difficult and much less likely to be successful in terms of separating those two surgically and preserving all of the hearing function that we would like. Sometimes, especially in NF2, we'll see tumors that will grow actually within the cochlea itself. And so when we find a small tumor within the cochlea like this, we don't operate on them. If there's good hearing, we wait, because taking the tumor out is very detrimental to the hearing if we go inside the cochlea. These little fine membranes are so easily ruptured, and they destroy the hearing if they're ruptured. So we leave those alone. And in a more advanced, whoops, sorry, wrong direction, more advanced tumors, you'll see here is a tumor in the internal auditory canal in an NF2 patient. And you can see it looks like a bunch of grapes. See all these little different compartments. And that's typical in NF2, that they have many different foci where they start. And in fact, in this patient, they come out and invade the cochlea too. And so it would be really impossible to completely remove this tumor and save the hearing because of the extensive invasion into the cochlea. In fact, when in this patient, I'm sure they already had a significant amount of hearing loss. Here's another tumor that's shown that's impacted into the internal auditory canal. And the fact that the nerve fibers for the cochlea come out and splay here into these little ganglion cells mean they're very weak anatomically and structurally, where they've separated from the tumor at this point. And so a tumor that's impacted out in the canal also is very difficult to remove and save any hearing. So what about if we say, well, let's just wait and watch? I think often that's the recommended treatment. Let's keep an eye on these tumors before they get really large and see how long can we hang on to the hearing. And we did a study quite a few years ago, where we said if patients had really good hearing to start with, they didn't drop very quickly. If patients had kind of okay hearing, but not great hearing, they dropped more quickly. And the patients who had pretty bad hearing to start with, they really dropped out fairly quickly. And so you say, well, what does this mean? If you put all these patients together over a longer period of time, would the curve look something like this? The tumors are growing slowly, or they're excreting factors that may be deleterious. And over time, it goes down if we were to say, let's go out to 10 years instead of just over 3 or 4 year period. And I think that in general, that's the pattern we see. And there's certainly studies that talk about this. This is a little chart that we put together looking at the different surgical approaches for trying to preserve hearing. You have to forgive my radiation slide. We don't have much on that, but I can tell you that of the patients where we observe their tumors, if the results go up into this quadrant, it means their hearing gets better. If it goes down into this quadrant, it means both their pure tones and their word discrimination score gets worse. And you can see that when we were trying to save hearing with the suboccipital middle fossa approach, often the results were to go in this direction. So if it's safe to wait and watch in the small tumor, you might save hearing longer, but I'm going to talk to you about a different paradigm for that as well too. And these are patients that have unilateral schwannomas and not NF2 related tumors. This is looking at long-term outcomes after using the middle fossa approach. And so in terms of what happens if you take out the tumor much later down the road, 4 to 14 years later, how's the hearing going to be? And in this particular group of 5 different studies, they said that 64% of the patients continued to have serviceable hearing out at the long-term follow-up. So there is some recognition of the opportunity to save hearing and have it be preserved for a long time if the surgery is successful. Now, how can you predict if the surgery is going to be successful? I've told you some of the anatomic factors and electrical factors, but I also want to say that we are getting a little bit smarter about genetic factors. And when we look at the different types of mutations that occur within the NF2 population and within the sporadic population, they're scattered throughout the whole NF2 gene. But we do know from, this is a very early study that we did, but from accumulating all of these kinds of studies about the different mutations, as you all know, there are some mutations that are much more mild and there are some that are much more severe. And depending on where what type of mutation is in the NF2 gene and where it's located, we can now have a little bit better opportunity to predict what's going to happen based on the severity of the mutation. So a tumor might be the same size in 2 different patients, but one may have a mild, a mosaic type of a a mutation or a missense mutation, whereas others may have a more severe mutation. And I think we would want to move ahead more quickly and try to do something to help those that have a more moderate or severe mutation. The genetic severity correlations do correlate with hearing grade, and they also relate to a number of other things like age of onset, the presence of schwannoma or spinal schwannomas, meningiomas, and the date of first treatment and so forth. So this is a young woman that presented first in 2017, and you can see that there's a tumor in the internal canal on this side and a teeny little dot on this right side. And 4 years later, they've both grown and they both have taken up more contrast, particularly this one on the right side. And I'd say, is there a chance now to take out these tumors and save hearing? There's a possibility, but you can see that the tumor's grown substantially. And had we taken it out at this size, we probably could have saved hearing. This size, it's more like 50-50 proposition. You know, would we prefer to, knowing if they have a bad genetic mutation and they have a small tumor, would we prefer to take out the tumor sooner? Yes, I would. This is the same image, a small tumor here that's grown over the 4-year period. This one also has grown somewhat. We're not exactly the same plane there. This is the 13-year-old woman with hearing loss in the left ear. It's diagnosed with blurred vision. The right ear has normal hearing. Speech discrimination score 100% in the right, 92% in the left. And 3 years later, when referred for tumor growth, then we had to decide, can we safely take one of these out? This is a 9-year-old boy, a very similar scenario where a couple of years earlier, little smaller tumors, but still quite lateral in the canal. And here you can see 2 years later. So is it better to take these out sooner or later? That's always a very difficult question, and it's one that has to be answered individually. But for some patients, I prefer to try to take them out sooner. What about the preoperative auditory brainstem response? Does that help? If we measure how long it takes for the electrical signal to get through the nerves, yeah, it can help. If we see that they have normal wave scores all the way through, then I think it increases our likelihood that we're going to be able to save the hearing. We did take the tumor out of the right side on this young man. There's a tiny little speck here left, so we're going to have to follow that. There's a little bit of tumor left, but fortunately, even though there's a little residual, the hearing held up well. This is both the pre and the post-operative audiogram with 100% discrimination in both ears, or 100% in the left and 98% in the right, which is the operated ear. So fortunately, his was preserved. We could consider taking out the tumor on the other side. Now, in a patient who presents with this kind of tumor burden, that's quite a different story. Here's a fellow who's got quite a bit of hearing loss in the right ear and the left ear. His speech discrimination score is 94% in the right ear, which is remarkable, and 76% in the left ear. It's interesting, isn't it, that with this kind of tumor burden, that his clarity is still so good and his pure tones are not very good. But it would be very difficult for us to remove those tumors and save his hearing. So what are the trends in terms of NF2 treatment that pertain to hearing? Well, in the 90s, most patients got surgery. Few people got radiation. Bevacizumab hadn't really been introduced at that point. What about the last 10 years? Actually, you see a much increase in terms of use of bevacizumab and a decrease in both surgery and radiation. We're much more likely to try to preserve hearing with using bevacizumab. This is a follow-up of a 30-year study that is a really interesting study, and that about 40% of the patients underwent treatment within 5 years of diagnosis. So, but there is more of a tendency to wait at this point. So to summarize surgery for NF2, it's difficult to save the hearing. It's difficult to save the facial nerve too. There are other complications associated with surgery. we really can't cure a genetic disease with a knife, unfortunately. And recurrent disease, new tumors can pop up, and some patients just get tired of having surgery, especially when they seldom come out better than they went in. Observation, when we just watch tumors, the rate of tumor progression is about 30% at 1 year, 64% 2 years, and 79% over 3 years in NF2. Larger tumors correlate with poor ABR and decreased balance function, weak VEMP, but they're not associated with change in the pure tone average, as we mentioned earlier. The discrimination score declines at a little slower rate than the tumor growth does. And you see that a drop in discrimination, 5% in 1 year, 13% in 2 years, and 16% over 3 years is what was summarized from this study that Scott Plotkin did a few years ago. But long-term observations not usually advised in younger patients if there's a potential for taking the tumor out and saving the hearing. If there's not a potential for saving the hearing, then observation may be weighed favorably. What about stereotactic radiation in NF2? Hearing preservation gets worse over the long term. It doesn't really matter if it's fractionated or single dose. I don't see any difference, even though many people say, oh, it's better to get fractionated. I think the cumulative effect of radiation is that hearing goes down. The tumor control rates are reasonably good, but we're concerned always about a malignant change in tumors that have been radiated. It's still uncommon, but 50% of those patients that get a malignant tumor are in NF2 associated tumors, which only represent 5% of all schwannomas. So in general, we tend to steer away from radiation. And you can see that the overall long-term hearing post-radiation in NF2 patients is a slowly progressive downward course. And so the long-term hearing preservation is not really good in these 4 long-term studies for hearing post-radiation. What about surgical salvage following stereotactic radiation? Well, it's very difficult to save any hearing after a tumor's been radiated. And generally speaking, the hearing is gone after the radiation anyway, but surgery on top of radiation is not a good scenario for trying to preserve hearing. Sometimes we will not remove all of the tumor in a previously radiated tumor, and the facial nerve outcomes are not as good as if the patient's not had prior radiation. Let's talk for a minute about hearing rehabilitation. Osteoconductive devices, these are the bone conduction implants that will take the sound from one side to the other side. When you have bilateral tumors, it's really not a sound strategy. It's not something I would recommend. What about contralateral routing of signals? People who wear a hearing aid on one side can pick up the sound in a poor ear and send it to the better ear. And this may be a reasonable thing to consider if one ear hears well and the other doesn't. While things are going on, it may be a useful device. And I would say 20 or 30% of people who use these cross aids like them and use them frequently. What about a cochlear implant? Well, if the cochlear division of the nerve is preserved in surgery, and if it still responds to electrical stimulus, that may be a reasonable thing to consider. And if the cochlear nerve is not preserved, auditory brainstem implants do give a measure of sound awareness and sometimes open set speech. So what do we do, a cochlear implant or auditory brainstem implant? The auditory brainstem implants, when they're accumulated, showed only about 12% open set speech understanding. Some patients do much better than that, but most of our NF2 patients don't get a lot of open set speech understanding. This means without lip reading. However, they do have a great deal of help from getting visual cues that helps lip reading. So I do think it's useful. And some reports have said up to 80% of patients get word understanding, but that's not the bigger series, which just says about 12%. What about the result of hearing from a cochlear implant? When the cochlear nerve's preserved but hearing's lost, in general, the response is much better than for auditory brainstem. There's possible long-term decline if new tumors grow. We have a small series that we presented some years ago that had an average follow-up of about 9 years. of patients who had a cochlear implant following preservation of the cochlear nerve with loss of their hearing. And their ability to understand words was excellent in all but one of them. They had 22% word understanding, but these others had very good word understanding. And in fact, most 5 out of the 6 could use the telephone, and they had long-term preservation. So I think it's an option to consider early on. If we think we might move the tumor and save the hearing, great. We'd like to do that as early as possible. If the hearing is preserved, then we consider removing the other tumor as well. If the hearing is lost but the cochlear nerve is intact, we'll electrically stimulate that nerve 2 or 3 months after surgery. And if sound is detected, then we'll go ahead and consider cochlear implant in that ear. What about just decompressing the internal auditory canal? If we open up the bone around the canal, does that make a difference? It's hard to tell. When we look at the literature, it may be useful. It's uncertain. Since I told you earlier, I don't think compression has a big role that it plays. It may be devascularizing the tumor itself, but it does seem that it gives some measure of help. What about removing the second tumor when the word discrimination is poor or when the brainstem compression is significant? We have to always consider, we don't want the brainstem to get compressed to the point that it could cause a stroke or death. For medium-sized tumors, we generally observe them while the hearing is serviceable and then remove them when the hearing gets poor. For larger tumors, if they're really compressing the brainstem, removing them and putting in an ABI is a reasonable thing. With electronic communications today, some patients choose not to have ABI. They're able to communicate digitally, and that's a great blessing that we have now that we didn't have 20 years ago. We avoid radiation. Bevacizumab, Dr. Jordan's going to talk about. So I'll just summarize and say surgical resection is not really great for hearing. Observation, progressive hearing loss is the key. I mean, it's something we will see over time. Stereotactic radiation, not really good. We really need better treatment options. And so that's where Dr. Jordan comes in. An ounce of prevention is worth a pound of cure. You know, guy walks up and says, I'll just have an ounce of prevention, please. If we could figure out a way to stop these tumors from growing or prevent them from growing, we'd be much better off than trying to reconstruct the auditory mechanism, which is so fine and detailed that it's difficult. You know, we may be able to block the damaging proteins that are secreted from the tumors. We may be able to block the bad influence of our own immune cells or harness our own immune cells to fight the tumors. Maybe if we restore the NF2 protein with gene therapy, we could prevent further hearing loss. These are all possibilities. And, you know, we have seen recent gene therapy successes with intervention in the eye and in the brain. Spinal muscular atrophy has been, really gives me great hope seeing what's happened. And I think that getting to gene therapy for NF2 would be really important. So I'm going to stop there. I think my time's going by too quickly, and just thank our many collaborators and all of the folks who have helped to fund these studies and the things we've worked on over the years, including the Neurofibromatosis Midwest and NF Northeast and all of these institutions. So I will stop there and turn it over for questions. Thank you so much for your attention today, and thanks for allowing me this opportunity. So are there questions?
Dr. Welling, there are a couple of questions in the Q&A section. I don't know if you see that on your screen.
Let's see here. Let me go to that. Q&A, yes, thank you. So, Bill, what's the process for determining the degree of genetic mutation of the schwannoma? Do you start with a biopsy? If so, what's the minimal size of a tumor to get a biopsy? That's an important question. In many patients, you're able to actually determine the genetics through blood tests. Some were not. If we can't determine it through a blood test, then we can determine it through biopsy of the tumor, and it doesn't take a lot of tissue. It's actually a very small piece of the tumor. It may be also obtained by obtaining a peripheral tumor if we're able to remove a tumor that's under the skin someplace and send that for biopsy. If we can't see the mutation in the white blood cells, we can sometimes find it from a peripheral tumor as well. And then how's a schwannoma tumor size measured? What dimensions? The common way is to measure them in 3 dimensions, to measure the diameter, the length, the width, and the height. It's actually more accurate if we measure the volumetric dimensions. So using an algorithm to outline the tumor, then we see the volume of the tumor. And so in our studies, we always look for a change of 20% or more on the tumor volume. And I think that that's actually easier to then compare, especially with smaller tumors that are hard to measure, but we like to measure them volumetrically. Thank you for those questions, Bill. Are there other questions? Let's see in the chat. Do I have any comments on the success of the diamond knife dissection technique? I looked that up recently, and the diamond knife is just another surgical instrument. It is an instrument that is sharp and useful. We have a number of different microsurgical instruments. We sometimes in the past have used lasers to help us debulk the tumors. There's a device called an ultrasonic aspirator, where the device uses ultrasound to break up the tumor and then suction it up to help us decompress the center of the tumor. Typically, when we're taking them out, we'll remove the center of the tumor first, and then we'll collapse it down, and then we'll peel it off of the nerves that we're trying to save. So the diamond knife dissection technique is just another type of a knife that we use. I don't use the diamond knife. I think it's the group in Japan had talked about it, a neurosurgical group there. It looks like it's a nice sharp knife. There are certain aspects of doing the tumor dissection I don't want it to be too sharp. Actually, I like it to have an end that can fit between the capsule of the tumor and the nerve, and get in there and not actually cut the nerve, but just kind of dissect it off the capsule of the tumor. So there are a number of different little tiny micro instruments we use to try to take these out. Thank you very much. Let's see. I think, are there any other questions? Thank you for the happy anniversary wishes, Natalie. I think that's nice. Okay. Well, I don't see any other questions right now, unless I'm missing some. In that case, I'll just thank you again and say I really appreciate the support of the NF community. The most significant award I think I've received in my career and doing this work was one that I received from the NF2 crew, which is a support group out of Columbus, Ohio, for speaking at their meetings. I've really cherished that little trophy they gave me, a little award, and then also just a really nice award from the Children's Tumor Foundation for excellence in science. And really that it falls more on the wonderful collaborators we've had over the years. And I'm very appreciative for all of the help and direction and the super collaboration we have on trying to get these things resolved. So thank you all for your support and your patience. And it's really a real privilege to be involved in this work. Thank you.
And thank you so much, Dr. Welling, for being here today. We enjoyed your talk, and happy anniversary.
Thank you so much. All right. See you.